surgery today. And it's Wednesday, it's hump day with Dr. Earle. And so this is the time I get to spend with you guys, and we get to kind of discuss things, answer all your questions, and you get to know me a little better, and you also get to learn about plastic surgery. So as you know, all plastic surgery topics are game. But today I want to start the discussion with something that I've been asked to kind of go over again. It's been a little while since we've talked about this, so I thought we should go over it again. And what I'm talking about is the ultrasound guided BBL or Brazilian butt lift, otherwise known as liposuction with fat transfer. Okay, so as you guys probably know, all of my BBLs are ultrasound guided. Okay, and I use the ultrasound to help me during fat transfer to the area which we will call the danger zone. Okay, and so I use it so that I can see the tip of my candle in that area to try to make sure I know where the tip of that candle is, and make sure that it's not too deep, that it's not kind of beneath the muscle there, and in the area where the big vessels are that can potentially lead to very dangerous outcomes. Okay, so what I use for that is a device called the Clarius. Okay, so I'm going to just kind of point that up there. Let's see if you guys can see that, but it's called the Clarius. Their little logo is Ultrasound Anywhere because it's a portable and mobile device. Okay, and the cool thing about it is that it's not really attached to any cables or wires. So it's actually quite a small device, and you can see that the device here. So that's all it is, a handheld device. Kind of just fits right there in your hand, and you can use it quite easily. So because it is so small, I can kind of use the device in one hand, I can guide the cannula with the other, and once I know I'm in a good position, then I can go back and put the fat into the area that I need. Okay, so it's a very, very cool device, very easy to, I can travel with it, I can move around with it, and it's not attached to anything because it uses basically a Wi-Fi signal that you can then go to, put the images on your iPad. Okay, so all you really need is that Clarius app, which is here, and right now it's sleeping, we're not using it, but all you need is that Clarius app, and then from there it's going to project all of the images, and so then I can project it to either an iPad or I can project it to an Apple TV, which I have in the OR if I want it to kind of be bigger, kind of a big zoom type picture. Okay. So a lot of people ask, how do you use the device inside the OR? Because of course this in and of itself is not sterile, and you can't, it's an electronic device, you can't really sterilize it. So what we do is that we use, a sheath to cover it. And so you have a little package that kind of looks like this one. This one in particular comes from Safer Sonic. It's one of the ones that we use here. And so I'm just going to go ahead and open one up for you guys. So the whole thing comes sterile. Once you open this up, you have to open it sterilely inside the operating room. You got to put all the contents onto your sterile table. Okay, and it comes with a few things. So one of them is the sterile ultrasound gel. Okay, so all ultrasounds require gel so that basically the sonic beams can pass through well and then project that image. Okay, and then of course you have to have a way to cover the ultrasound, which is this sheath that we have here. Okay, so the sheath comes sterile. You have an assistant who's not sterile, and then you put in your sterile hand with your sterile glove into the sheath. The assistant kind of puts that here for you, and then once it's there, you grab it. It's all sterile there. Then you use your other sterile hand to bring the sheath over it. Okay, and then it remains inside there, sterile. Okay, and it has some extra tapes then that you can use to then basically close off the top and tape it closed, and then you have your nice sterile device there, and you can use that in the operating room. Okay, once you have that, then you open up your gel, you put that over the skin, and then you're good to go. Okay, now I wanted to show what it looks like. So I have an image here. Okay, this is one of the images. So this is, I don't know if we can zoom in there a little bit or you're able to see that. Okay, but this is one of the images that we took in the OR. We have a stand where we put the iPad. So the iPad's on the stand. Here's my reflection there. And then you can see here the different layers. So of course the very top layer is the skin. All right, just beneath that you have what we call the superficial fat, okay? So that's the fat between the skin and a fascial layer that we call scarpa's fascia, okay? So you have the superficial fat there, and then you have this white line that comes, the first kind of white line that you see that comes across, that's scarpa's fascia, okay? And then beneath that you have the deeper fat layer, okay? And that deeper fat layer is kind of where you want to start off your BBL. You want to start off expanding that deeper fat layer, which is between the muscle and scarpa's fascia, right in here. Okay, so in this here, my cannula tip is right there in that spot. It's between scarpa's fascia here, and then this that you see down here. So this very kind of thick white line down there, that's the fascia overlying the muscle. Okay, the gluteus maximus. All right. So the muscle is thicker under here, so you have your fairly thick muscle underneath there, and so that's where you don't want to be, right? That's the no-go zone right there. So you don't want to be in the muscle. You want your cannula tip to be right here, in between the fascia of the muscle and the scarpa's fascia, and that what we call the deeper fat layer, and that's where you want to start the BBL, to build up that layer. Afterwards, once that layer is built up, you can then go back and then put some fat between the scarpas and the skin and build it up a bit in the superficial layer as well. So it's kind of like, you know, if you're going to build a mountain, you're going to stop with the bottom part of the mountain first, and then, you know, the upper part of the mountain. But you don't want to go too deep. You do not want to go deep to that muscle fascia, into the muscle, or deep beneath the muscle, because that's where the vessels are, which are the superior and inferior gluteal vessels, which are the ones that if you puncture the vein especially, the fat can get into that vein, and from there basically has direct access to the lungs, and that's called a fat embolism. And if you have massive fat embolism, then that could unfortunately lead to, you know, very, very dangerous scenarios, ICU settings, and even death. Okay, so that's what we try to avoid with the use of the ultrasound.
Do you use it when you're fixing hip dips?
So, okay, so yeah, so that's a great question. So now we can turn the camera over here, so we can do a little kind of a sketch of what I'm talking about as well. So this is my very kind of crude drawing of the backside of a buttock. And so this is, of course, this is the back, these are the thighs, and that's the buttock here in the middle. And so people always ask, you know, do you use the ultrasound for the entire procedure? And the answer is no. I don't, okay? I use the ultrasound when I'm in the area which is described, as we mentioned earlier, as the danger zone, which is this area here. It's approximately 8 centimeters from the midline out laterally, okay? So from that gluteal crease out to the side, about 8 centimeters, that's what we describe as the danger zone. Approximately in this area here, and not too far below it, in that area there, is where you have the superior gluteal vessels. Okay, and those vessels are deep. Okay, they're not superficial. They're beneath the muscle. So when I'm in this area here, the D is for the danger zone. So when I'm in this area here, that's where I use the ultrasound, because I want to make sure that when I'm putting fat into this area, I am above the muscle. Okay. Then this here with a little kind of green stripes on there, I call that my buffer zone. Excuse me. Because, you know, not every patient reads their anatomy books, right? Anatomy varies from patient to patient. So I want to have a little buffer there. Typically, I give myself another 2 to 4 centimeters. So I use that as my buffer zone. So I use the ultrasound for that buffer zone as well. And then once I'm outside of that area, so basically beyond 12 centimeters from the midline, then I don't use the ultrasound anymore, because that area is considered safe. Okay, so even if I were to inadvertently get beneath the muscle all the way out here, there are no large vessels there that I could puncture and cause a fat embolism. Okay, so here I'm a little bit more cavalier. I know that once I'm out here, you know, even though I can feel it, even if I inadvertently get, you know, too deep in this area, it's not going to cause an issue. So the question was, do you use it for hip dips? No, I don't use it for hip dips, because the hips obviously are out here, and that's, you know, a safe area. There's no large vessels there, so the chances of a fat embolism are almost, you know, pretty much almost zero. Okay, so that's where the ultrasound comes in. We want to use it right in here. So another common question that we ask is, you know, Dr. Earle, since you started using the ultrasound, has that added a lot more time to your BBL? And again, so the answer is no. Of course, I've gotten a lot better with it now than when we first talked about this, which was about either August or September of last year. Even back then, because you're focusing it on that area, it doesn't add a lot more time to the BBL. So that's great. So the patient's not under general anesthesia for really any much longer time than the patient would be otherwise. And of course, it's a lot safer for the patient when I can see the tip of the cannula, essentially turning a blind procedure into one where I can see that tip of the cannula when I'm in this area to make sure that I'm not anywhere near some part that would be dangerous.
So did you choose this mainly for safety, or does this help with results?
No, it's really mainly a safety issue. It does not have to do with results per se, because we're still putting the fat in this basically in the area where you're supposed to put it, right? So let's take things back, I don't know, 5 years or so. Back then, of course, there was overall less experience with BBLs. Actually, around that time, it was actually recommended that maybe it would be a good idea to put fat in the muscle, because that way you can add more volume, okay? And that's where you got like those really kind of like super drastic, like extreme vixen types of looks in one round, right? But of course, the downside to that is very, very dangerous, okay? And we've learned a lot since then, and there's been unfortunate deaths. And at one point, it was even reported that the fatality rate for the BBL was about 1 in 3,000, which I do not think is right now in today's time. I don't think that's the case. But back then it was, because actually putting fat into the muscle was encouraged. And it was encouraged not only by other surgeons, but by the patients themselves, because patients wanted like these really drastic looks and they wanted it in one round. But it's a way too high of a price to pay. Way too high of a price to pay. At least for me, I won't do that. So now we've learned, okay, and actually certain states and certain countries forbid the placement of fat into the muscular or submuscular plane. Because we've learned a lot from that experience, and there are several recommendations that are given to us by the American Society of Plastic Surgery and the aesthetic societies that are the following. Number one, you want to use a rigid cannula. Okay, you don't want a cannula that can bend, because it can inadvertently bend into an area where you don't want it to be. Okay, of course, we're talking now for the classic way of doing this, which is blind, which is basically doing it by feel, right? You have one hand, which is typically the left hand if you're a right-handed surgeon. The left hand gives you the feel, tells you where you're going, and the right hand is the one that moves the cannula. Similar to when you do liposuction, okay? So number one, you need that rigid cannula. Number two, you want the tip of the cannula to be blunt. So you want a blunt tip cannula. It can't be too small. It should be greater than 4 millimeters, preferably 5 millimeters, okay? With a single hole. All right, those are the fat transfer cannulas that we have here at Pure. So we use a rigid, single hole, 5 millimeter blunt tip cannula, okay? All right, then the next thing that is basically recommended is that you do not inject fat in the submuscular plane, okay? Do not inject fat in the submuscular plane. So the fat needs to be placed above the muscle, okay?
So for patients who do not have a lot of fat in their buttocks, is it harder to transfer?
Sometimes it is. So remember, we have basically that limited space. So we don't want to go beneath the muscle. Okay, that's too dangerous. It's not worth it. It's not worth anybody's life. Okay, so we have that. The space that we have is in between the muscle and the skin, and within that space, like I mentioned there are two fat layers: the deeper layer and the superficial. But once you fill that space, that's about it. So that's when you guys will hear me, time and time again when I tell you. That people are like, Doc, I want you to put in everything. I want you to put in 2 liters in there. And then, or sometimes after the surgery, you're like, Doc, why didn't you put in all my fat? Okay, well, I've said it multiple times. So we have limited to that space. So therefore, what is the rate limiting step is going to be the elasticity of the skin in that area. Okay, so skin always stretches. It's kind of like a spring. See, like I'm kind of doing my fingers, kind of springs. Okay, but it's going to reach a point where it cannot stretch any further, okay? Think of it like a balloon. You're filling up a balloon with water, okay, one of those small water balloons, and you're filling up with water. Eventually it's getting to the point where the balloon's just going to pop, right? But not all water balloons are similar. There's some water balloons where the skin is really stretchy and you can make that water balloon very, very large and it won't pop. And there's some water balloons I'm talking about skin, but that I mean the balloon itself, but there's some water balloons where it doesn't stretch much, where it's kind of tight, and so you try to fill that with water. Number one, it's tough to fill it up, and number two, you can't get it that big, and if you try, the thing pops, right? So your buttock's not gonna pop, right? I'm not gonna have exploding buttocks. That would be quite a mess, but what does happen is that we try to put in the fat, and we get to a point where it just won't accept, excuse me, it just won't accept any more fat, okay? And then when we take out the cannula, the fat actually comes out the little hole. So it kind of just shoots it back out. And I know that once that starts to happen, I've gotten to the point where it just won't accept any more fat. We reach our rate limiting step, and that's as far as we can go.
So we have a question. If I'm having fat transferred to the hips, how much fat is required and how much fat do you estimate is retained?
Okay, so how much fat is required, that varies greatly from patient to patient. Again, it has to do with how much hips it wants, how their skin elasticity, how far it stretches. So it can be a wide range. It could be a wide range. Now, how much is retained is a good question. So the overall retention rate that I found in my practice over 1,000 BBLs is, I say it's approximately, you lose about 30% of the fat. But when I say that, I mean that globally. I mean that both like in the central buttock, so kind of central buttock area, and in the hip area, okay? If you were to break it down a little bit further, it's probably less, it's probably about, you lose probably about, say, maybe, I don't know, anywhere between somewhere like 20% maybe in this area, and more like 40 to 50% in that area. But again, I'm talking about averages. Not every patient is alike. I've had patients that tell me they've retained almost 100% of their hips, and I've had patients who tell me that they've retained very, very little, say maybe only 20% of the hips. Can I like look at a patient and just by looking at them tell who's going to be the retainer and who's going to be the one where it all gets absorbed? I can't really do that. So that's one of the things that when I talk about the BBL and how it's a terrific procedure because you can really change the shape of someone's body, but the downside is that it's somewhat unpredictable. That is one of the things that I mean. So there are there are a few things that are out of the surgeon's control. And one of them is, for example, your fat retention rate. How much fat you retain, and how much fat do you retain in what areas, and are you going to retain the fat symmetrically? Those are all things that may or may not happen. Okay, what if the patient tends to sleep a little bit more on one side than another, and puts a little bit more pressure on one side than another? What if the foams are placed differently? All these things can contribute to the final outcome. And of course, you're not going to really see your final outcome until at least 3 to 4 months out. Diet after this procedure also is very, very important. So, feeding the fat, I do believe in that. I do believe that if you have a diet that is high in healthy fats, such as, avocado, salmon, also milk products such as milkshakes and ice cream, that you're going to have a higher overall fat retention rate than you would have if you didn't do that stuff. You got to maintain your weight or gain a little bit of weight, especially in those first 6 weeks. If you lose a ton of weight in the first 6 weeks, that's not good for fat retention. You definitely don't want to be in some sort of like keto diet. That's a fat burning state. You don't want to be in ketoacidosis, during recovery from a BBL. All these things contribute to the final outcome.
How long does it take for you to perform a BBL surgery, and do you only perform it under general anesthesia?
So I do only perform it under general anesthesia, and how long it takes again also varies a lot. So it can be anywhere from an hour and a half to 2.5 hours. So why the kind of the wide range? Again, it has to do, some has to do with BMI. So like if you're a low BMI patient, it's going to be faster because there's less fat to remove, right? Your BMI is, they say, my lower limit, which is 22, as opposed to say your BMI is 33. And then the other part is, what does the patient want? Well, does the patient want a very natural look and just want to fill in some hip dips? Well, that's going to make it go faster as well. Does the patient want me to put in as much as I can, given that skin elasticity issue that we talked about? That's going to take a little bit more. And then of course, how easy is it to extract the fat? Is it around one patient, never had surgery before, and it's, has that fat that kind of just really kind of like just seeps out? That's going to go faster. Maybe as opposed to say around two patient has some degree of fibrosis, scarring, makes it a lot tougher. That's going to go a lot slower. So there's a wide range there. Some which I can somewhat predict, but some of it which I can't. I won't know until I get there.
I read that Cell Saver allows patients to recover quicker. If I get Cell Saver at your office, will that allow my results to also be better?
So no, Cell Saver, similar to the ultrasound, is about safety and recovery. It's not about results, okay? Results is more about, technique, how I transfer the fat, how I do the liposuction. So the Cell Saver, what that does is that it, when you do lipo, you're not just sucking out fat, but you're sucking out some of that tumescent fluid, you're sucking out blood, and you're sucking out fat, okay? And then you allow the fat to separate from the bloody tumescent fluid, okay? And then you take that bloody tumescent fluid and you run it through the Cell Saver, and the Cell Saver will separate your blood, your red blood cells, from everything else. And then we can give those back to you almost like an auto transfusion. So what does that mean? It means that your overall blood loss for the procedure is less. So say you would have dropped, from a hemoglobin of say 12 to a 9. With the Cell Saver, then you're going to drop from a hemoglobin of 12 to say a 10.5 or something like that. That's just an example I'm throwing up, okay? But the point is that we're giving some of that blood back to you, so the overall blood loss is less, so your recovery is going to be better because you're going to feel stronger, you're going to be more up, more moving about, you don't feel as weak, as lightheaded, less passing out and things of that nature.
We know post-op, the body goes through a lot of changes after BBL. When are the results permanent?
So I like to say that we can't even really talk about, what the results are going to be till at least 3 to 4 months. And that's not to mean that they're permanent at that point in time. Actually, I've had, in my experience, patients, that follow, kind of what they're supposed to do, have continuous improvement in the results, even over the course of the first year, okay? But certainly we're not going to really know much till at least 3 to 4 months out, okay? And here's the thing, here's the most, I've always said that BBL, kind of like real estate, is all about location, location, location. BBL is all about foundation, foundation, foundation. So bringing in a good foundation, of course, is a great way to start. And if you have a great foundation, then you'll probably have, truly excellent results. But also, liposuction and BBL is not, not a complete substitute for good diet and exercise, right? It's not an either or. Both arguments are wrong. When sometimes we put up these awesome results, and you'll have somebody on Instagram and they'll be like, she should have done squats. I mean, I think that's really ridiculous. That's someone who really doesn't understand what we're doing. But so just doing squats is not going to get you to where you want to be. But on the flip side, just doing the procedure and then not doing anything, not doing any exercise, not watching your diet, just kind of just doing whatever you want, it's just going to get you back to point A all over again at some, it's further down the line. So the best combination is to do it all, basically, all right? To come in with a good foundation, to have your procedure, and then to maintain those results with an adequate and balanced diet and exercise program. And when I say exercise, you want the type of exercise that's going to maintain your BBL results. And that is mainly, yes, squats, okay, and basically, weightlifting, which can be either true weight or body weight, okay? If you need something for the heart rate, then I recommend high intensity interval training, okay? What I don't recommend is kind of long cardio workouts, okay? If you do a BBL, and then, unfortunately, for example, you become a marathon runner, you're gonna lose that BBL. Then you gotta think, what's more important to you? Do you wanna run marathons, or do you wanna keep your BBL? So that's something that I don't recommend, is I don't recommend long extended cardio type workouts because you'll lose a lot of that fat.
Can you get a revision to fix the hip dips?
Can you get a revision to fix the hip?
If the fat doesn't survive there.
That's all very, very patient dependent. So, if fat doesn't survive, like I said, that's nothing that was caused by the surgeon. So, revisions are not really more for whether fat survived or fat didn't survive. Again, that's completely out of my control. I can't do something to make the fat survive more or less. Part of it is genetics, part of it is the diet, part of it is the post-op care. Revisions are reserved more for like if there's like a really like gross, asymmetry, like something just looks totally off. Then that's perhaps something for a revision. But that's really all taken like a very, very case by case basis. There's no like absolute rules to that.
Is it harder to do lipo and fat transfer on someone that previously had a tummy tuck?
Not necessarily. Not necessarily. For the most part, it's if the fat wasn't really touched more during the first tummy tuck, in other words, an extensive lipo wasn't done during that first tummy tuck, then it's okay. There's not really any additional effort put in. Now, what really does matter a lot is previous like full body lipo, stuff like that. Especially if vaser or laser lipo was used previously, and the laser is the toughest one. If you had laser lipo before, trying to go back is is really tough. I mean, we have to it's almost like kind of like chiseling through concrete sometimes, trying to get through that, because it does leave a lot of scar tissue when you do that laser lipo.
So number one, what is your BMI for the BBL? Yeah. And based on your experience of doing over 1,000 BBLs, have you noticed a range of a BMI range where you see the best results?
Yeah, so the max BMI is going to be 33.5, okay? That's going to be the max. Now the range, which I think would be optimal, you don't want to be too skinny, you don't want to be too fat. So the optimal range is about 25 to 27 or so, somewhere there. I would say that's the optimal range, maybe even 28, but you want to be in that range, okay? So, and what's the minimum? Because there is a minimum too, and a minimum is 22, okay? The minimum BMI is 22. The optimal range, I would say between 25 and 27, and the max would be 33.5.
And what is the minimal hemoglobin level that you will accept?
11, okay? So if your hemoglobin level is 11, we can go ahead, but the cell saver is mandatory. Though I like all my patients to use it, even if their hemoglobin is 13. I would highly, highly recommend it, and it's part of the package here at Pure. But really, the absolute minimum hemoglobin will be 11. If your hemoglobin is below that level, then I won't do a BBL.
How long do you have to wear the faja post-op?
All right, so great question. So faja, usage starts off basically night and day. So you have to use the faja 23 hours a day for the first 6 weeks. Okay, so you're gonna wear that. You're gonna take it off just to like either shower, wash it. Sometimes you need an hour break, and that's okay. But other than that, you're gonna keep that faja on. Okay. Now, when I say faja, I kind of mean it in the global sense. Like, if you're someone that likes to do the A-Spanish method, that's fine. But you got to do it. You got to do it, 23 hours a day. Same amount of time period. Okay. Now, after 6 weeks, you can then scale down to 12 hours a day. So most patients like to use it during the day and take everything off at night, so they can be more comfortable. They can let the skin, try to breathe a little bit more, basically. And then you're going to do the 12 hours a day till at least the 3 to 4 month mark. And then you'll take it from there. I've had patients that are still in their faja at 6 months, at 8 months, and there's patients who are just completely sick of it by 3 months, and then they just throw it away and never want to see it again. So that's a little bit more variable after that period of time.
How long after the BBL can we sleep on our backs or sit down?
Yeah, so it's going to be 6 weeks. Okay, so in terms of sitting, for the first 2 weeks, you want to try to minimize sitting as much as possible. There are going to be circumstances where you have to sit, of course. If you're traveling by plane, you're going to have to use that BBL pillow. But overall, try to not sit as much as possible for the first 2 weeks. Between week 2 and week 6, okay, you can use that BBL pillow quite a bit more liberally. So you can use that, that booty or BBL pillow during that time. And then after week 6, you can start to sit normally. It's going to be a little weird at first, okay? It's going to feel a bit uncomfortable because you haven't sat for so long, and because you had the transfer, and you can have like some odd feelings and things like that, and that's okay. Eventually, everything tends to settle down, over the next few weeks or months.
When you first learned about the Clarius ultrasound for BBLs, how long did your training go? And when did you feel ready for surgery?
Yeah, so we first learned about it. I had first learned about it at a meeting. And it was in June of 2019. I finally got the machine by August, and then I started using it and not really charging anyone because I knew I wasn't an expert at that point in time. September I went to an official Clarius course, and I did that. I think it was a 3-day course there. Okay, and then after that, I just started basically implementing it with as part of all our BBLs. And it's part of the BBL here. So there's not, when you come here to have a BBL with me here at Pure, it's not like, can I get the ultrasound one or the not ultrasound one? No, there's no choice there. I mean, why would you mess with safety? So all the BBLs are ultrasound guided, okay, and that's just part of the deal, okay? That's just part of the deal.
Do you see yourself using this for the remainder of your career, ultrasound?
As long as I do BBLs, yes. So if I'm doing BBL, that's what I'm using.
Can I get?
Could it be the Clarius, or could there be some new technology? That's the one thing that can change, perhaps. Some different ultrasound type of technology. But as far as right now, there's really nothing much better than that. Handheld, portable, wireless, nice images. They keep updating it every few months, so I'm very happy with it.
Can patients get surgery if they're using accutane?
You don't want to be on Accutane at the time of surgery because it can affect your healing time. Okay, so you want to stop Accutane before surgery. If
you're transferring fat cells to the buttocks, in the future, if you gain weight, does it go to the buttock?
Yeah. So that's actually a very important point. So when you do liposuction, right? Or actually, let me bring it back a notch. Let's take it back. Okay. So let's talk a little bit about fat cells and fat physiology, okay? So after you reach basically adulthood, the number of fat cells is pretty much stable, okay? The number of fat cells is pretty much stable. What happens when people gain and lose weight is that the size of the fat cells goes up or down, okay? The fat cells become larger or smaller, okay? But they don't necessarily multiply. And I'm talking here in broad terms. There are some stem cells, there is a little bit of fat cells, blah, blah, blah. But in general, you can think of it this way. The number of fat cells remains the same, the size is what changes up and down. When we ask people to gain weight before BBL, are we asking them to do that because we think they're gonna get more fat cells? No, we ask them to do that because the fat cells become larger and they're easier to harvest. That's why we're doing it. Okay, some people make I've heard people say like, well, if it's the number of fat cells doesn't change, then why do you ask people to gain weight? And then that's the reason. The fat cells become larger, they become easier to harvest, okay? All right. Okay, so now, when you do liposuction, you are physically removing numbers of fat cells. You're lowering the number of fat cells, okay? And then, when you do a BBL, you're transferring those fat cells to a different location. And after everything's said and healed and everything else, 3 to 4 months down the road, whatever fat cells have survived are now permanently in that location, okay? So when you then gain weight, the size of those fat cells in their new locations are gonna go up. Now you have a lot less fat cells in the belly area or the flanks or the waist or wherever we took it from, and you have more fat cells in the buttock area. So the distribution of fat gain will be different, okay? So if for some very unfortunate reason you didn't do what Dr. Earle said, and he said, you gotta maintain your diet and your workout plan because that's the best of all worlds to do all three, right? Surgery, diet, exercise plan. And you gain a ton of weight, then the distribution, like you may not gain it in the belly, at least the superficial in the belly anymore, but you may gain it in the arms, you may gain it in the buttock where the fat cells have been transferred, or the most unfortunate and the one you really want to try to avoid is when you gain it in that visceral fat area, okay? You guys remember what the visceral fat is? All right, let's go over that again. So this is an extremely crude drawing of a belly on a side view. This is the belly button. Okay, this is your skin. This is your abdominal wall. Your abdominal wall is composed of your muscles, right? Like the rectus muscles, okay? All right, the fat that we're able to remove with liposuction is the fat in between the skin and the abdominal wall, okay? That's what we can address with surgery. However, there's also fat in here where you have your liver and your intestines and your stomach and everything else. So that fat that is deep to your abdominal wall, inside your abdominal cavity, that's the fat that we call the visceral fat, okay? All right, so when you gain, so say that you've had a procedure in the past, a liposuction procedure in fact, then you start eating, putting in calories like crazy, those calories still have to go somewhere. But the calories are not gonna go here anymore because we removed a lot of that fat. I mean, some of them will, but a lot of them won't. And so now that's made to be made thinner, okay, because we removed a lot of the fat there. But the calories are gonna go into your visceral fat, and that's gonna be made bigger. And that's when you have that kind of pregnant belly looking, kind of, looks like you're pregnant, but you're not. It's just all that visceral fat. That's what happens then, okay? So that's why you really, really want to try to avoid, significant weight gain after a liposuction procedure.
So for the patients who just want their hip dips filled, can they combine that with, let's say, breast reduction?
Typically, I don't do that. There are some rules here in Florida, so when you do something like a breast reduction, you're limited to removing only 1,000 cc's of fat via liposuction, and so then you would have to kind of split that and use 500 per side. And I mean, for some hip dips, that may be sufficient, but for a lot of them, it's usually not. So for the most part, I don't do that unless it's like something like pretty minor, and also if it's something that I don't really have to kind of flip the patient around. I typically, if I'm doing a lot of work in the front, so like mommy makeover or tummy tuck or breast reduction, I don't want to be flipping the patient, on their belly, basically.
Do you offer your patients Valium or something similar prior to surgery?
In general, no. I mean, if it's something that they've been taking and followed by their PCP, then if they need to take it before surgery, that's okay. Benzodiazepines such as a Xanax or a Valium, it's not something that's gonna interact that much with anesthesia or recovery, so that it's okay to take. But I'm not the the prescriber of the medication.
So we have a few questions about cigarettes versus marijuana. What's okay prior to surgery and what's not?
Right. So marijuana, so THC or CBD, CBD, in and of its own is okay. All right. That is actually okay. It's okay. It's in your system. We do test everyone. We do a urinary drug test, and if that's the only thing that pops up, then you're okay, and we proceed. Now, nicotine is not okay. All right, nicotine is not okay, and that of course is found in cigarettes. But sometimes, if you're wrapping your marijuana in some sort of like cigarette type wrap that has nicotine in it, then that's not going to be okay either. And also, if you're vaping but it has nicotine in it, that's not going to be okay. So we do test the urine for nicotine, and if the nicotine comes out positive, we cancel most surgeries. The only surgeries that we don't cancel with nicotine are just a straight up lipo, okay, with no fat transfer, or something that requires just a very small incision, such as breast augmentation.
After surgery, when do your patients start wearing foams boards?
Okay, they can start as early as the next day. So when you're waking up from anesthesia, we put in your stage 1 faja, and we don't put any of the foams and boards inside. Why? Because we know that first night you're gonna drain a lot. Okay, that's normal, it's common. There's a lot of drainage that first night. Doesn't make any sense to put in your nice foams and boards at that time when you're just gonna drain through everything, get it all messed up. You're just gonna end up throwing those out and getting some new ones. Okay, so we don't put in the foams and the boards that first night. You come in the next day, typically for your massage corradito, or you have your massage, and then after your massage, you can take your first shower, which you typically feels really good because you're feeling a little bit gross by then. And then when you put all your stuff back on, you can go ahead and put in your foams and your boards. So that's going to be like a little bit later on, post-op day 1.
Somebody says a comment, another doctor told me that ultrasound kills the fat. Do you find any truth in this or know anything about it?
Okay, that's a great question because not all ultrasounds are created equal. So there's a confusion there. And the doctor should probably have been more specific as to what he is talking about. So, all right, there's a type of lipo called theyre with a V. Okay, the theyre does use ultrasound energy. Okay, it uses ultrasound energy to basically heat up and melt the tissues. Okay, so if you're doing liposuction with a theyre, it is possible that that ultrasound energy can basically melt and kill the fat cells. Now, the theyre has different settings. You know, you can put it up really high, you can put it up lower. If you talk to the theyre reps, they'll tell you that if you put it at a low enough setting that it won't really kill the fat cells. I'm not sure I believe that. So if that's what your doctor was talking about specifically, then yes, it is possible that a theyre can kill fat cells, and I don't use a theyre. That's why I only use what we call PAL, or power assisted liposuction with a micro air. That is not the same as the ultrasound that's used for imaging. Okay, two completely different things. This creates heat and energy. This doesn't. This is ultrasound that's used for images. Okay, if I were to put this on my hand, there's no heat, there's no nothing. Okay, it's just bouncing ultrasound waves back and forth to create an image. This type of ultrasound does not damage absolutely anything. Okay, that's why, you know, when you do an ultrasound for your gallbladder or any sort of ultrasound imaging, it's very benign. There's no radiation to it. It doesn't damage anything. So that's why, you know, say people recommend to say, you know, ultrasound images as opposed to, let's say, a CAT scan, which is also fairly benign, but it does have some radiation to it. Okay, so you gotta differentiate. So ultrasound energy used in something such as a theyre liposuction, yes, potentially that can kill fat cells. Ultrasound used for imaging, absolutely not. Doesn't kill anything. Doesn't even disturb it. Okay?
All right, well, thank you for that. I know you have to go soon, so just a few more questions.
All right, let's do it.
To the THC versus nicotine, somebody asked, can I eat THC infused edibles immediately post-op?
Sure. I mean, just be careful. I mean, you know, you just use common sense. Okay. You immediately post-op, you're going to be on Percocet, right? You're probably going to be some pain medication. So you don't want to be adding like pain medication and a bunch of THC and then basically just like, you know, passing out or stuff like that. So you don't want to do anything that's, you know, dangerous basically. Okay. CBD, of course, you know, doesn't have the same effects as THC, so CBD is probably more tolerable. But again, remember, you're initially post-op. You're probably dehydrated from the surgery. You're probably a little bit anemic. You're going to be on pain medication. Okay, so you just want to, you're not going to be kind of the same way you were or before surgery. You want to take it easy, and you want to be very conscious about what you're ingesting.
Is birth control prior to surgery okay? If not, when should I stop?
Depends on the birth control, but in general, oral birth control or any birth control that has estrogen.
The patch was specifically asked.
Okay, any birth control with estrogen, you have to stop at 30 days before surgery. Why? Because estrogen increases your chance of a DVT or a PE, blood clots. Okay? So anything with estrogen, you gotta stop 30 days before surgery, all the way through 30 days after surgery. Now, if it's the type of birth control that only has progesterone, okay, like a little implant, the next implant, some IUDs with or without progesterone, things of that nature, then that is okay. Progesterone does not increase your chance of DVTs and PEs or blood clots. So that's the difference there. So that's why that can also be a little bit confusing. But certainly all the oral contraceptives have estrogen, so those are a no-go. And the patch, you'll have to check. You gotta check exactly what type of patch you have, what is in it. If it has estradiol or any sort of estrogen, then the answer is no, you cannot be on that. If it's purely progesterone, then that's okay.
Okay, last question. Massages, how many and how important is it post-op BBL?
Okay, massages are extremely important. Okay, very, very important. I know right now, unfortunately, with COVID and all that stuff, they're very, it's tougher than it usually is, but you really have to find a way to get it done, basically. Post-op care for liposuction and liposuction BBL is just as important as the procedure itself, okay? I can leave someone that looks perfect on the table, and if they don't do their adequate compression, they don't do their massages, they start sitting, then the results can end up being complete trash, okay? So extremely important, you want to do a minimum of 10, but that really is the absolute minimum. 15 or 20 is not unusual, and you want to do it with someone who has a lot of experience with post-lipo / lymphatic massage, okay? This is not the same type of massage that kind of you roll into massage envy. It's not the same thing, okay? This is a very specific type of massage for post-lipo or lymphatic type of massage, okay? And the massages have different goals depending on where you are in your recovery. So initially, one of the main goals of the massage is to get rid of the excess fluid. Okay, so that's a lot of what Corradito does here, because she typically sees patients post-op day 1, 2, 3. Okay, so you want to the initial goal is to get rid of the excess fluid so that you can develop seromas later, okay, or at least minimize the risk of a potential seroma later. Okay, after you kind of go through that initial goal, then the massages are important to kind of try to redrape the skin, try to get it as flat as possible. And then they become important to also minimize the risk of fibrosis, okay? They're the two most important things that you can do post-op to minimize fibrosis and to have the skin kind of drape back as best as you can is hydration. You want to drink 1 to 2 gallons of fluid a day. If you can get to the 2 gallons, even better. And the massages, choosing the right person and doing enough of them, okay? So, post-op day 1 through 5, you want to do massages daily, every day. Post-op day 1 through 5, you want to do that daily. After that, you can probably do about twice a week till you get to about post-op day 10. And then after that, once you get to your 10th massage, you can then continue weekly. And I know, like I said, scheduling is an issue, budgets are an issue, and I can understand that. But if this were the most ideal world and none of that was an issue, you'll be getting weekly massages for the first year to really get, truly excellent results, okay? But I mean, unfortunately, that's not realistic for most people, so we all understand that. So the minimum is 10, 15 or 20 is not unusual.
Thank you, Doc.
Okay. All right, everybody. Well, I hope this was very informative. I think we covered a lot here today. I just want you guys to kind of, throw us some ideas for Hump Day for next week. Let us know what you want me to talk about. And then also, let us know kind of what kind of guest speakers you would like to have on. I know we've had Corradito here. We've had some of the other people from the staff come over as well. I've been trying to find a nutritionist. I haven't really found one. If somebody knows someone in the nearby area that might be interested in doing a Hump Day, that would be terrific. Because I think that's also really important. All right, guys. Well, this has been great. And I will see you guys next week on Hump Day with Dr. Alex Earle. Take care. Ciao.